So hi, folks. I'm Tristan Knight. I am a pediatric oncologist in Seattle at Seattle Children's Hospital, and a clinical assistant professor at the University of Washington. So with Oncology Data Advisors, we were looking for things we could discuss in relation to childhood cancer awareness month, which is September, every September. So I have basically decided kind of wanted to talk through basically what childhood cancer looks like from a biological standpoint, from a treatment standpoint, and kind of really compare and contrast it to adult oncology, which is, what I think most of the audience here would be very familiar with, but there are quite distinct differences in pediatric cancer compared to adults. So firstly, Childhood Cancer Awareness Month, every September. It was established initially to raise awareness about the challenges faced by children and their families with cancer, and to highlight the importance of research and funding for pediatric cancers and promote advocacy for better treatment and support systems. September was chosen for two main reasons, really. September marks the start of the academic year, so it's time for back to school and for new beginnings for many children. And so the idea resonates with the mission of fighting childhood cancer, and symbolizes hope and for a future in which children can return to school and normal life after treatment is completed for them. It also was chosen because it aligns well with the other major cancer awareness months, October being Breast Cancer Awareness Month, for instance, and so it aligns with that calendar quite well. One of the symbols that people have probably seen for Childhood Cancer Awareness Month is the gold ribbon. The use of ribbons to symbolize awareness for different kinds of cancers was popularized in the 1990s. Pink was the breast cancer awareness one that was the most famous one, I think. Gold was chosen for children because gold symbolizes the preciousness of children, their well-being obviously being of utmost importance, and the adoption of the gold ribbon for childhood cancer awareness was initiated by advocacy groups and quickly became a rallying symbol for this cause. It's used globally now every September to show support for childhood cancer patients and their families. Funding for pediatric cancer research has historically lagged well behind adult research. It's only a small proportion of the NCI's overall budget, despite being one of the major causes of childhood death. The aims of Childhood Cancer Awareness Month are therefore to highlight the need for more research into pediatric cancers, which are biologically different from adult cancers and thus require unique treatments. And we'll go over that in detail coming up. Advocacy during the month focuses more often on lobbying for increased research funding, clinical trial promotion, and supporting legislation aimed at improving care and resources for childhood cancer. So it's a major part of our funding and for our support efforts for childhood cancer. So now I want to talk about the biological differences between children versus adult cancers. So cancer obviously affects both children and adults, but the types of cancer and their biological characteristics, including their incidence rates and the treatment approaches, are very significantly different between these two populations. The first thing worth mentioning is that the cancer types themselves are different. Pediatric cancers are often derived from progenitor or embryonal stem cells that arise during development and essentially persist past the developmental stage when they're useful, and then are able to kind of explode out and cause malignancies later on in life. Pediatric medulloblastoma, retinoblastoma, neuroblastoma are typically derived from embryonal tissues that have failed to differentiate properly and are persisted. So these tumors are more often developmental in nature, reflect problems of differentiation of normal tissue rather than external damage or carcinogenesis. As such, pediatric tumors are often pretty immature under the microscope, have more primitive appearances, and give it less heterogeneity compared to adult cancers. So, around this point, there actually have been fairly robust efforts on the idea of screening for pediatric cancers early on, but what turns out that because these cancers are often embryonally derived and often are pretty normal tissue, is that if you screen everyone with childhood cancers, you pick up ones that you don't actually need to treat and just cause a lot of anxiety and worry. So neuroblastoma is probably the most famous example of this, where you have 4S neuroblastoma, which is disseminated neuroblastoma that involutes on its own. You don't need to treat it unless it's causing compromise from the size of the tumor itself. But these tumors involute without any management specifically. And there was quite a large effort in Japan, I believe, to screen for these tumors. But all that ended up happening is that anxiety was produced, and you had a lot of unnecessary treatments and surgeries happening to remove these tumors, which it turns out you didn't need to do anything for. And that's happened a few different times in pediatric cancer where there's an effort to screen for a cancer that doesn't actually, turns out, need to be screened for or managed. So it complicates the management and screening process for a lot of these cancers because there is certainly some degree of I wouldn't say normalness, but some degree of greater common. They're more common than they would appear based on treatment alone because they do tend to involute some of them on their own in some cases. Obviously, it isn't the majority of them, but it does complicate issues. Adult cancers, on the other hand, they're more mature usually and arising from more differentiated tissues that become dysregulated over time. So for instance, adult glioblastoma, mature glial cells that undergo mutations due to prolonged exposure to radiation or mutagens, possibly, versus a pediatric medulloblastoma, they are derived from embryonal neural precursor cells from early brain development. The incidence rates are also different, obviously. Childhood cancer is much rarer than in adults. About one in 200 per 80, so about 1 in 285 children were diagnosed with cancer before the age of 20. Adults, it's actually more like 1 in 3 over their lifetime, so much rarer in kids. In the US, about 17,000 people under the age of 19, so 18-year-olds and lower, we diagnosed with cancer every year. The commonest one by far is leukemia, especially B-cell ALL. That is the commonest childhood cancer. And altogether, leukemias account for about a third of all childhood cancers. Brain and CNS tumors are about a quarter of them. Other cancers, neuroblastoma is the commonest extracranial solid tumor. Lymphoma is common. Renal tumors, Wilms tumor in particular, are also common. But you tend to kind of progress rapidly down into various sarcomas from there. Adult cancers, as I said, are much more common. The NCI estimates around about 1.9, 1.8 million new diagnoses in adults per year, with pretty sharp incidence increasing over the age of 50 or so. Most common in adults: breast, lung, prostate, colorectal, about half of all adult cancers, so much less heterogeneous than the number of types of cancers in children. Lung cancer being the overall leading most common one, I believe. The risk factors are also different. So in kids, both kids and adults can have genetic predispositions to cancer. The role of genetic mutations is more pronounced in children, though. So retinoblastoma, for instance, is a cancer of the eye, most often functionally solely caused mutations in the RB1 gene, which is tumor suppressor gene. That is kind of the typical example where that is a very, very genetically determined cancer. Other syndromes, Leishman, Becker-Flügelman, are also strong cancer predisposition syndromes. If you have a cancer predisposition syndrome, for the most part, those are going to arise in early childhood. You'll find these. For adults, there is also genetic predisposition as an option, but it plays a smaller role. Lifestyle and environmental factors tend to be a bigger role in adults. It's not to say it doesn't happen. For instance, the BRCA1, BRCA2 mutations for breast cancer are probably the most common, but overall, those are a minority of breast cancer cases compared to the overall population. Environmental and lifestyle factors I alluded to a little bit. Children obviously can have environmental exposures, radiation, or prenatal carcinogens, but those play a relatively minor role. Compare that to adults, where things like smoking and alcohol and diet are major risk factors for things like certain kinds of lung cancer, colorectal cancer. Those are less common in pediatrics. There's been less of a cumulative exposure occurring. Certain infections, though, can be quite significant. So Epstein-Barr virus, EBV, is very linked to certain kinds of lymphomas and raises the risk of cancer development. In adults, I mentioned kind of smoking being a major risk factor, alcohol as well, and environmental things accumulating over time and causing more cumulative damage as well. Biologically, cancer is also different between kids and adults. It's not just a matter of which kinds of cancers have developed. Even within the same kinds of cancers, so if the same kind of tumor, nominally speaking, will be different between kids and adults. That's not just histologically, but the molecular mechanisms as well, genetic profiles, and the tumor microenvironment, responses to therapy, all these things are different. And to explore these biological distinctions can help to explain why the treatment differs, as well as why survival outcomes are so different in kids versus adults, even with the same kind of cancers. So firstly, the genetic and molecular differences. So a key difference between pediatric versus adult cancers, even with the same histology, is the mutational burden present and the type of genetic alterations present. So pediatric cancers generally have a lower mutational burden than adult cancers. Um, Many pediatric cancers are driven by genetic alterations present from birth or early development and are not linked to environmental or lifestyle factors. The relatively pristine genome of pediatric tumors contrasts with a much more mutation-laden genome in adult cancers, which have accumulated more mutations over time. In pediatric cancers, there's often a specific driver mutation that is, in many cases, diagnostic when it is detected. Or if not diagnostic, then it is one of a small number of genes. So, for instance, in ALL, some kinds of pediatric ALL and neuroblastoma, there are very specific mutations that can cause that. ETV6 RUNX1 is probably one of the most common drivers in pediatric B-ALL and disrupts normal hematopoietic development. In contrast, adult ALL is a much more complex genetic environment, and that can complicate treatment efforts to translate across the different, the age gap between adults versus children. Tumor microenvironment and immune response is also different. And so in pediatric cancers, there's a less immunologically mature environment. Children's immune systems are still, not fully developed, and that can influence how those tumors can evade immune detection. At a fundamental level, cancer is an immunological failure to detect tumor cells and remove them. In pediatrics, that may largely be due to the immaturity of the immune system and inability to detect these cancers, versus in adults, it can often be related to just a senescence, if you will, of the immune system. So for pediatric tumors tend to have lower PD-L1 expression, which is a key immune checkpoint molecule and target. So because those tumors are less reliant on evasion by the PD-1, PD-L1 interactions, immunotherapies that target that axis are often less effective than they might be in adult cancers. In adult cancers, chronic inflammation and immune evasion are kind of hallmarks. Tumors exist in a microenvironment filled with immune suppressor cells, Tregs, MDSCs, high levels of PD-L1 expression can contribute to immune escape. So for instance, melanoma and non-small cell lung cancer frequently overexpress PD-L1, causing them to avoid destruction, but making those targets very attractive for those kinds of cancers. In pediatrics, there's a relatively small number of diagnoses that we can actually use those treatments on. They exist and they're effective in those treatments, but it's less important for our treatment strategies. Similarly, angiogenesis and tumor vascularization is different. So pediatric tumors are often highly vascular due to their origin in developing tissue, which makes sense, right? They're embryonal tissues. They have lots of blood vessels and require a high blood supply. Neuroblastoma and Wilms tumor, for instance, have intense angiogenesis driven by VEGF, but the vascular networks tend to be more mature, ironically enough, and more structured and less chaotic than adult tumors, which can influence how those respond to anti-angiogenic therapies. Adult tumors have generally much more disorganized blood vessels, and the chaotic angiogenesis is kind of a hallmark of some adult cancers, and that can create a more hypoxic environment in the tumor, which drives further genetic instability and mutations and aggressiveness, and makes them reliant on things like hypoxia-inducible factors, HIF-1 alpha, which can be targeted through angiogenesis using things like bevacizumab, which are more commonly used in adult cancers. Again, we do have some options we can use to treat those, but they tend to be a minor subset versus a larger group of tumors that are targetable that way. Tumor growth and proliferation are also different. Pediatric cancers generally exhibit pretty rapid growth, reflecting their tissue that they arise from being embryonal and more actively dividing and growing from that standpoint. So for instance, Ewing sarcoma, rhabdomyosarcoma are probably two of the more common pediatric sarcomas, and they tend to arise and grow very rapidly, allowing early diagnosis and aggressive treatment to be crucial. But the rapid growth rate generally means that these tumors are more susceptible to chemotherapies, which obviously target more rapidly dividing cells more easily. Adult cancers obviously can still be aggressive and still grow rapidly, but compared to the speed with which pediatric cancers can grow, they tend to be slower. Indolent cancers in adults, prostate cancer, for instance, being a very good example of that, are can take years before they become clinically significant or noticeable. And that's really quite uncommon in pediatrics. Generally speaking, once you have a pediatric tumor, it's going to grow and come to attention pretty rapidly. Um, that also complicates treatment of efforts in adults because those tumors are growing more slowly and have more time to accumulate genetic mutations, which is less the effect of pediatrics, where you generally have, as I said, a single driver mutation that's causing the major uh, response. Responses to treatment are also different. I often tell kids, parents, when they're diagnosed with a new cancer, not to go on to Google and Google it, which is obviously the first thing they're going to do anyways. But I tell them to make sure that they're looking at pediatric specific data because the treatments and the outcomes are very different, again, even in the same kinds of cancers. So I always make a point of asking families if they have any experience with cancers in their family, which many of them do, because someone who's had, adult AML, for instance, versus pediatric AML, nominally the same kind of cancer, very different outcomes, still serious in kids, but much more treatable in adults. Pediatric cancers are often more sensitive to multi-agent chemotherapy regimens. So for instance, pediatric B-ALL, we have cure rates of around about 90% right now, which is obviously spectacular. And that's using more or less just chemotherapy. There's not much in way of immune checkpoint, immune cell therapies in that to get that 90% roughly. And that's due to the higher sensitivity and fewer genetic mutations that are carried by these cancers in children. Adult cancers generally are more resistant than pediatric tumors, have multiple different mechanisms that can be seen in pediatric cancers, but less commonly drug efflux tumors, accumulation of additional mutations, changes in the microenvironment. These can all be seen, but are less common in pediatric cancers. The targeted immune therapies I want to talk about a little bit as well. They've obviously revolutionized cancer treatment, but the replication varies pretty significantly between pediatric and adult cancers. Pediatric tumors have fewer targetable mutations, which limits the ability to address them. So for instance, AML I've mentioned a few times, IDH1, IDH2 inhibitors are obviously very useful in adult AML. That's not as useful in pediatrics because a much lower percentage of tumors have those mutations. They're there, we do see them, but they're not as common. Some cancers in kids do have those, and where we are able to target them, they revolutionize therapy. So for instance, neuroblastoma, which is as I said, it's the commonest non-intracranial solid tumor in peds, has very successfully been targeted with anti-GD2 antibodies, and that really has improved outcomes very, very effectively. That's being studied in a number of frontline trials in pediatrics. In adult tumors, as I said, the checkpoint inhibitors, it's like pembrolizumab, for instance, that target PD-L1, the PD-1, PD-L1 axis, those show pretty remarkable efficacy in frontline trials for melanoma and non-small cell lung cancer. But the lower mutational burden and different immune environments in pediatrics tends to preclude some of those treatments. We are looking at it in many kinds of different cancers, but it's less advanced, I guess, than in adults. The long-term and survivorship data also is quite interesting. So for long-term survivors, obviously for adults, you want adults to do well and survive as long as possible and minimize late effects. But for kids, treating a 2-year-old versus a 75-year-old with AML, you're much more concerned about late effects in someone who's 2 because they have potentially 78, 80, whatever many years of life going on. So that will guide your treatment decisions. And so we know that certain things like radiation are extremely harmful to growth and cognitive development, and try to limit that use pretty heavily. Obviously, we don't have any other choice, but in certain treatments, we basically are trying to get away from using radiation at all. Similarly, certain kinds of cancer therapies, we'll try and limit them or use them only in certain age groups where we try and avoid damaging and causing late effects. Again, obviously the first principle is to achieve a cure, but where possible, a lot of pediatric trials are kind of trying to scale back and have fewer late effects or avoid radiation altogether. To summarize then, so both children, obviously, and adults develop cancer. The types, the malignancies, the underlying biology, the risk factors, treatment approaches are all different between the different populations. Pediatric children as well tend to be more resilient than adults. Obviously, someone who's 5 or 10 or so has much greater reserve and can be given much more intense chemotherapy than adults. This kind of gets the idea of, fit versus non-fit, which is a major, determination in adults with what kind of cancer treatment is given. In peds, theoretically, obviously, we do this. I mean, obviously, if someone's, got, liver failure, we're not going to give them the same medications we would give someone who doesn't have liver failure. But that is a rare enough thing that happens that we don't really tend to address it in our trials. Obviously, if someone's not eligible for trial, we don't enroll them in that trial. But the idea of fit versus non-fit isn't really a thing we worry about in pediatrics. We use organ function, obviously, but it's not as much of a thing that we use. Now that we discussed pediatric cancer and how it's distinct from adult cancer, I want to talk about a little bit about the clinical trial environment, which is also very different from adults. So I'm not going to explore the international context because I'm not overly familiar with it, but the North American context I am familiar with. And so in North America, the main group that trials operate underneath is called the Children's Oncology Group, or COG. It's a clinical trial group supported by the NCI. It's the world's largest organization devoted to pediatric cancer research. COG conducts clinical and translational trials from any age, infant, adults, adolescent, AYI populations, young adults. Almost every center in the US that treats children with cancer, and also many in Canada, are part of COG. There's more than 200 member institutions, almost 100 active clinical or translational trials at any given point. And more than 90% of folks, of children and adolescents in the US diagnosed with cancer are treated at COG member institutions. Many of the ones who are not part of that are done with St. Jude and St. Jude protocols. But obviously, there are far more treated on COG, it being a larger group. The way this is developed basically kind of occurred organically over time. So early on, it was recognized that, because pediatric cancer is more rare than adult cancer, if an institution is only getting, 3, 4, 5, whatever, of a certain diagnosis a year, to do a trial with that would take just an unfeasibly long amount of time. It would never work. You could never do it. So it was recognized pretty early on, back in the 50s, that you needed to develop a consortium approach where you pooled data and had common trials that you used to guide cancer care for kids. So this was started in 1955 with consortium-based focus on childhood cancer research. And then a number of these kind of grew over time. But the mid-1990s, there were 4 focus on childhood cancer research that were funded by the NCI. One of the earliest ones that I alluded to was founded in 1955, and that was the Child's Cancer Study Group, or CCSG. That group aimed to standardize treatment protocols across various hospitals and medical centers treating various kinds of childhood cancer. Mostly they focused on the more common cancers, which again are still rare enough that you could never do a single institution study unless you were somewhere very large, like say St. Jude. And basically pooled data, and over time have really driven forward the survival rates for these. Data was able to be pooled, and you could figure out things, what worked, what didn't work, much more rapidly than if you're trying to do it at an institutional level. The next major group that helped form COG was the Pediatric Oncology Group, or POG, which formed in 1980 based on earlier regional collaborations. Like CCSG, POG was formed with an idea of creating standardized clinical trials for children with cancer. It also was more focused on solid tumors, whereas CCSG was more based on leukemias. But both groups recognized the importance of developing large-scale collaborations across institutions just based on the rarity of these cancers. These 2 groups were kind of more broad, though. There were also 2 other groups, which were the Intergroup Rhabdomyosarcoma Study Group and the National Wilms Tumor Study Group, which was focused on specific kinds of cancers. And in the year 2000, all 4 of those groups merged to create the Children's Oncology Group. So you may see older studies that are referred to, these older designations and older studies, but currently there's one group that is across North America, and that is the Children's Oncology Group. So one thing I tell my parents whenever they're coming in to be diagnosed or have start treatment, one common question is, should I go somewhere else, or is this the best place to be treated for this kind of cancer? And With very few exceptions, the answer is it doesn't matter where you're treated, because you're going to be treated on the same protocol no matter where you are. Obviously, that's not always true if it's a rare cancer or something that's not as common, or if you have local experts in certain kinds of cancer, that's different. But for the most part, the frontline trials people are on, it doesn't really matter where they're going to be. They're going to be enrolled in these trials, um, assuming the trials open at that institution, which again is a little bit variable. But for the most part, treatment is very standardized across the institutions in North America when there's an open trial. And that's really driven the field forward from, things like, the 1960s where there was no cure rate. It was basically a, um, always lethal disease, pediatric cancer, to now, where, as I mentioned, we have, about 90% cure rates for pediatric BALL, less for other diseases. But it's really impressive to see the stepwise improvement we've developed, which again, to have that in a disease as overall rare as different kinds of pediatric tumors, you really need that collaborative approach. I'll close up by talking a little bit about challenges and future directions. So despite the huge amount of progress that's been made by COG and the earlier groups, there still remain a lot of challenges. Pediatric cancer receives a disproportionately small amount of research funding compared to adult cancers, even though childhood cancer remains one of the major causes of death by disease in children. So future directions for the field involve increasing access to precision medicine. So that involves expanding the availability of genomic testing and targeted therapies to children. There's this idea of being tumor agnostic, where mutations are identified that are specifically targeted by certain agents, and the treatment is based around the mutation, not the tumor type. And that's really gaining some currency in pediatrics, where we have things like mutation-specific drugs that target those, but are kind of just being integrated now into the pediatric cancer protocols for those specific diseases. Another area we're working on is addressing disparities in cancer care. That includes disparities between low income and high income, minority groups, those living in underserved areas. We know, for instance, for a fact that people enrolled on trials have better outcomes than ones not enrolled on trials, even if they're on the control arm. Just the higher degree of engagement is enough to actually improve outcomes. And lastly, a continuing focus on survivorship. As more children survive cancers, the importance of survivorship research grows, as does the importance of being able to reduce the impact of the chemotherapy that we're using, where a lot of the frontline trials now are actually looking at not so much expanding treatment, but scaling back treatment and seeing if you can give less cancer therapy and still have good outcomes. So with that, I will close my section of the talk and open things up to any questions that are available. Thank you so much.